away from radiology, radiography, I would say. In the exams, you are not going to be, most centers don't ask, and in DNB, we don't ask to do a chest radiograph, but you will definitely be asked how to do it. I mean, you have to know about it theoretically. In fact, more than theoretically, I would suggest that some radiographs you must do yourself. You must go to the room and do it once yourself, once, twice, thrice, because if you do it, you will remember it. And to learn about what are basics of radiographic positioning, which is such an important topic for your lifelong. When you are working in your own clinic or otherwise, also, you must know how to take a radiograph. You must know the basics. And chest radiography is one thing which is mandatory to all radiologists. And if you do not know it, you don't know radiology. And I have the privilege of welcoming Mr. Sashi Kumar Shetty. He is a acclaimed teacher. He's assistant professor of medical imaging technology and Department of Radio Diagnosis at KC Hegde Medical Academy, which is a NIIT university in Mangalore, Karnataka. Mr. Shetty has already taken several lectures for our ICRI programs, and I have requested him specially to take at least two lectures for our students, because this is something you will not learn otherwise. You will not read also, but this is something which is asked in the exam, and apart from exam, you need to know it. And so a very, very warm welcome to you, Mr. Shetty, on the National Board of Examinations platform. And it's over to you, sir.
Thank you very much, ma'am, for the introduction. Uh, Very good afternoon to each one of you. Today I'm going to give a lecture on basics of radiography positioning and chest radiography. Whatever I'm going to explain in another 1 hour, I kept it very simple. And if you have any questions or any clarification, you can put it in a chat box. I will answer at the end of the sessions. In the beginning slides, I kept very basics of radiography positioning. If you wanted to know much about radiography, you need to know basics of radiography. If you know that, then it's not only just radiography. You can learn any extremities or any spine or radiography. It's very easy. It's not tough at all. So I'll start with today's my session. And first, at most, I thank the panel, especially Anjali ma'am, giving me the opportunity to take a class on, for the, I heard it is all for the radiology technologist. And as ma'am mentioned, I've been taking classes for the ICRI, the students or the faculty who attend last 1.5 years. So image formation, I think all of you are very well aware of the image formation. You know, example, I'm giving you the example here. If it is, see, example now 100 rays, if it is passing through that, just a minute, yeah, 100 rays, if you are passing through that example, if 90 X-rays, if you pass through the lung, because since the attenuation is very low, it will, and 90 rays will be reached to the film, and where the bony structure, example, the 50% of the X-rays are absorbed by the bony and 50% of the or 50 rays will be reached to the film. If 90 rays, if it is reached, we'll call as a high density. As you see in the image here, in the surrounding of the hand X-ray, you can see the darker structure. That's because of the high density. Where in low density or lower density, because you can see here, as you can see here, the ulnar and radius is a more brighter. It means most of the rays are absorbed by the bone and the lesser rays reach to the film. As the lesser rays reach to the film, lesser rays to reach to the film will be more brighter. So this is how we are differentiating the bony structure and the soft tissue and the air. These are the main, three structure will form the image formation during the rays, X-rays. So whenever you taking radiography, there are certain points you need to keep it on mind. Certain things I am included in the slides. If for example, superimposition, that's very important whenever you're taking any radiography. You can see the anatomical superimposition to the size, shape, positioning, or angulations is very important. And the second one is adjustment to the structure. Based on this only you are able to differentiate. And the other point is optical density. So this is how I explained in the previous, how the blackening and the brightening of the film appears based on that. Then fourth one is contrast, because this is the major role differentiating between the density of the two different areas. Then magnification, especially whenever you're taking a chest X-ray PA view, magnification will take the big role. I will explain it later. And the same time, the shape the shape of the distortion of the any part. So superimposition, adjustment to structure, optical density, and contrast is the part of my explanation. The last slide, in between that, magnification and the shape of distortion I added in slides because that's the most important whenever you're taking chest X-ray PA view. See, whenever you're taking radiography, it's very important to uh, have the technical factors. So, in case if an lesser exposed, instead of giving here 50 kVp and 10 ms is required, if you're given somewhere 40 kVp and 5 ms, it will cause the insufficient density. Okay, where if it is given proper 50 kVp and 10 mas for the adult knee radiography, you can see the proper density. Somewhere, if you're given more density, example, you're given somewhere 70 kVp and 20 MAS, you will have the too much high density. See, but nowadays, most of the places CR or the digital radiography are installed. If it is insufficient density, after taking radiography, we've seen somehow you can increase the brightness. I've seen most of the time, most of the students or the radiologist will ask, we can give the lesser exposure and we can adjust the brightness. No, it is always to have the proper technical factors to get the proper density image. Then later that brightness adjustment, the contrast adjustment nowadays in CR, DR, it is available. So that's possibilities are there, but you should follow the ALARA principle whenever you're giving a radiation exposure. So always whenever taking radiography, you know, see here I'm giving the example. You can see the patient is in PA positioning here, and the same way patient is in a AP positioning in a standing. But when you taking after taking the radiography, if you are well aware of the radiography, you are able to make out this is the PA view, this is the AP view. Means you need to know. Sometime most of the time I seen that AP view can be identified by the heart size, but sometime AP view also, if you properly the distance from the film or from the cassette to the focal distance, if you are properly maintained, even still in AP view also you can avoid the magnification of the heart. So placing a marker, right or left marker, is very important. So you don't mind about PA view or AP view, but placing the marker is very important. Or sometime you understanding the film technique, that is also important. You can see the clavicle here or see the clavicle here, it is placed in AP view. This all I'm going to explain it later. So anyway, placing the patient and keeping the marker and understanding the image is very important. That's what I meant. The same time, keeping the X-ray room clean and neat, creating the good environment for the technologist, maybe radiologist, the patients is very important. And whenever you're taking the radiography, it can be PA view, chest X-ray view, lumbar spine, whatever, having the proper comfortable dress for the patient and making them comfortable, it's very important whenever you're taking the radiograph. And as well as uh, clear instruction for the patient. When the patient come for x-ray, you know, the particular area, whichever area we are going to take, that area, any metal or any radio opaque material to be removed so that you can avoid the repeat exposure. And whenever you are taking radiography, you have to have the proper transfer, patient transfer technique. There are a lot of other transfer techniques are there should be followed so that you can have the better x-rays or radiography. And as well as whenever you're taking radiography, having the patient identification, because nowadays CR and DR is there, but still whenever you're entering the patient data into the monitor, as always should be cross verified, because there is maybe a patient example is Anand, maybe Anand, there might be a two Anand. So whenever patient is comes, when you call the patient as a Anand, so you had to cross verify with the patient hospital unique ID number, and based on that only it should be cross verified and should be taken. So there are a lot of incident it's taken place. You might be remember of that. Instead of taking the Anand A, we might have taken Anand B patient X-rays on that. So whenever you're taking radiography, is always should have the proper cassette size and to be taken. Example, here you can see that patient A, the cassette size, it was both the patient, it was uh, uh, patient visited to department, radiology department to take the hip X-ray, APU. Here, patient A, it is taken is 35 into 43 centimeter, means 14 into 17 inches cassette. Usually, whenever in a radiology department, we don't mention cassette size on based on centimeter, based on inches, most of the places in India. So, cassette size will start from 12 into 10 inches, somewhere 15 into 12, 14 into 14, and 17 into 14 inches cassette is in India used. In earlier days, 10 to 8 cassette size also were used. After introduction of the CR or DR, not DR, CR, so smaller cassette, 10 into 8 cassettes are not much used because 12 into 10 is more sufficient, and sometime AP and lateral also can be taken by using the divider. That's the purpose. So these are the cassette size 12 into 10 inches, 14 into 14 inches, and 17 into 14 inches is the commonly used in India. And in India, 17 into 14 inches cassette is the maximum size very used. In if you go to European countries and all, 17 into 17 cassettes is used for adult chest X-ray radiography or femur radiography purpose. So here now wanted to take the hip radiography, and the cassette placed 17 into 14 or 35 into 43 centimeter. Where in for the patient B, you can see 18 into 24 means that is a 10 into 12 inches cassette used. So you can see that after taking CR radiography, there is an option for collimation or option for crop. Like in after taking 17 into 14 in the patient A, then they crop, they wanted to see the only AP of the hip joint. You can see because of the distortion or because of the magnification, the image clarity or the image contrast difference between the area it lost. So when it is taken in the proper 17 into sorry 12 into 10 inches of the patient B, you can see here it is, you can see the image how beautiful, right? So it means always we should take the radiography with a proper cassette size. Instead of I wanted to take hand radiography, if you include this, if you use the 17 into 14 cassette also, you can take the radiography. But the image, how it will differentiate, that is shown here. And same time, adaptation of exposure techniques to patient is very important. Example, this is in particular to chest X-ray I'm giving here. Sometime patient condition is having some old age, suspected pneumothorax, or any atrophy or emphysema. That time we need to have the decreased technical factors, means KVP-MS2 should be reduced. When you are taking radiography with suspected pneumonia or pleural effusion or edema or ascites, so or hydrocephalus, something like that conditions, you need to have the increase in the technical factors is very important, so that one way you can reduce the radiation exposure to the patient, and then another way you can have the very good image quality. Example, see here now one patient A here, patient right lateral decubitus, chest radiography showing fluid level. You can see in the arrow here, fluid level. The exposure technique we are given increased here because we are going to see the fluid level here. We are not concentrating anything about lung. We don't want to see any parenchyma here or anything vessels. We don't want to see. We wanted to see the air fluid level. Okay, so that's purpose. When here what we need to go, we need to give the increased radiation exposure. Now example, patient B. Okay, here we are suspected with the air fluid level. We are going to see the air fluid level here. In case here, if you give in a higher increased exposure, KVP is high, what will happen? This air, you can see here, and the fluid level, you are not able to differentiate much. Okay, so that's the reason you always should have the decreased radiation exposure. So that's what always, depending on patient condition, you should give the radiation exposure to the patient. So as as you know, all of you aware of that radiation exposure, we all will follow as low as reasonable achievable, ALARA principle. Time, distance, and shielding is very important. I request everyone to not to neglect this a small exposure. Whenever I seen that most of the places I am part of this radiology since 2004. The last 20 years I seen this taking radiography in a different hospitals. I worked in a different country where most of the time in India, I seen that they neglect this is small exposure, one chest X-ray exposure, very less, or one fluoroscopic exposure is very less. No, there are a lot of article, lot of research are coming out. You can see that. So always you should follow the ALARA principle, and as well as this three, time, distance, and shielding should be maintained. At the same time, it's very important to know about body plan since you're all from the radiology MD background. I no need to explain much about this thing. You are well aware of this. So this is very important. Sagittal plan, coronal plan, or horizontal plan, or oblique plan. This is very important to know because these are the main important factor where whenever you're positioning the patient, you are going to explain that. So I'll come to the positioning terminology. Uh, Erect. When it comes to erect positioning, you know, all of you, maybe patient is in standing or sitting positioning. If it is standing or sitting positioning, it is known as a erect positioning in positioning terminology. Okay, sometime patient might be a posterior aspect or against to the cassette, means anterior part might be touched to the cassette, or posterior part anterior aspect against to the cassette, or posterior part touched to the cassette, or right or left side of the patient might be touched to the cassette. All everything we know as we as the positioning terminology known as a erect positioning. You can see here patient uh, uh, facing towards the cassette, PA view. You can see here patient right side is touching to the cassette, known as a right lateral. Both the time the patient are standing, so it is known as a erect positioning. At the same time, there are other where decubitus, in the decubitus also, this can be supine decubitus or prone decubitus or lateral decubitus. There are three views. Okay, can be called as a decubitus only, but where on you can see in the topmost image, patient is supine, where posterior aspect on touched on the cassette. Okay, it means supine positioning, where anterior part of the patient is touched on the table, prone positioning, and you can see here lateral side of the patient is touched on the table, left lateral decubitus. The same time, the other positioning, semi-recumbent positioning, usually this positioning is taken during the portable radiography, maybe in ICU or in the ward radiography. So what is the anterior posterior view, where X-rays pass or enters to the anterior part and exit to the posterior part, known as a anterior posterior. At the same time, posterior anterior, where the rays, X-rays pass through the posterior part and exit to the anterior part. So that's a posterior anterior view. And where is the lateral view? Again, lateral view will be maybe left lateral or right lateral. You can see here, this is the image receptor in the patient's right side. So this is the right lateral view because right side of the patient touching to the cassette, known as a right lateral view. See here, this patient is supine positioning. Patient is in supine positioning, but this is known as this radiography. After taking this radiography, it will be a lateral view. After taking the radiography, it will be a lateral view because it's also called as a left lateral, because since the cassette is in the left side, or bucky, vertical bucky we call, it is in the left side. So left lateral view means now patient is in supine, horizontal X-rays passing through the right side of the right lateral of the patient and exiting from the left side of the patient. So this is usually, it is taken patient when not able to stand in erect or sitting positioning, but we had to take the left lateral positioning, lateral X-ray of this particular patient. So that time we will use this supine positioning method. Also, it is called transverse method. Sometime some books are mentioned, or some books are mentioned as a horizontal radiography. There are different names. Okay. So here one more. Now patient again not able to stand, not able to sit, but we need to take the PA view, posterior anterior view. That time patient will be made it as a lateral positioning on the top of the X-ray table or on the top of the um, trolley, cassette placed anterior to the patient and exposed from the posterior to where X-rays are exiting from the anterior. This is called posterior anterior or left lateral decubitus. Okay, the patient is in the left lateral decubitus, sorry. So this will be, this also called as a decubitus of posterior anterior view. Sometime we need to have the angulations. Patient is supine positioning now or lateral positioning, whatever the positioning, we wanted to give the angulation in case this tube, you can see the X-ray tube angulated towards foot or towards pelvis. It is known as a caudate, where the X-ray tube towards the head, it is called as a cranial or cephal angulation projection. So as I mentioned, see here now three different positioning you can see in this image. Patient is in standing. Here it's called upright, or patient is in supine, or patient is in lateral, any lateral view. Okay, but at the end, we are going to get the AP view. At the end, we are going to get the AP view of the skull. Maybe three different positioning, but at the end, we are going to get the AP view only in this projection. So sometime, patient is in AP positioning, but the rays are angulated. You can see here. So that called as a AP axial projection. Okay, if the rays are perpendicular, that's called the AP view, true AP view. Okay, so here you can see the rays is passing in the center in the mid sagittal line, parallel to the mid sagittal line. Okay, parallel to the mid sagittal line, but still angulated in A image, B image. In A image, you can see angulated, and when you see towards the B image, it looks like a perpendicular, but it is known as a AP axial projection. Sometimes X-rays are passed through the edges of the patient body. Example, this is the temporal bone projections. Okay, so that time we called this projection as a tangential projection. It was taken for the zygomatic arch. It is known as a tangential projections. Sometime we need to take RAO, right, anterior oblique. Most of the time I seen that LAO and RAO always they get confusion. That's the reason I added here slide RAO, right side of the patient is touched to the cassette, where patient are tilted towards the posterior from the PA view, tilted towards the posterior, known as a RAO, right anterior oblique. Okay. Same time LAO, again left side touched, patient left side is touched on the cassette, where patient tilted towards the posterior, known as a LAO projection. Again, see here LPO, left posterior oblique. Here, see here, the left side patient part is touched, and where patient tilted towards the anterior is known as a LPO. In case if it is right RPO, again our right side patient will be touched, and tilting the patient or rotating the patient towards the posterior will be known as a RPO, right posterior oblique. And whenever you're taking landmark radiography, it is very important to know the landmarks of the patient. If you don't know this, you are not able to take the proper radiography. You are not able to make the central ray of the central ray. Radiography rays are it should be centered in particular area only. Then only you will get a optimal contrast image. So if it is taking chest X-ray, PA view or AP view, you can see here lower border of the scapula, where T7 or thoracic 7 or D7 dorsal 7 will be appeared at the level of that. So we are going to make the centering ray here. Okay, so always you should know that the landmarks of the patient is very important. Maybe example jugular notch, which level thoracic vertebrae are coming. Maybe for the thyroid cartilage, when you are taking C-spine AP view, you must know about it. And the same time, example lumbar spine, you are taking a lumbar spine, iliac crust. Now iliac crust at the level which vertebra comes, that is must when you are taking the radiography of that. And same time, we had to, when the patient comes, we had to think in our mind what kind of body habitus of this patient. You know, all of you very well are aware of that there are 4 different type of body habitus. So it's very important to know this one. I'll give you why it is very important. Now example, patient one visited to department for the chest radiography, hyperesthetic body habitus are there. Now red color, you can see this red color is a cassette you're going to place. Okay, since this patient is in a hyperesthetic. Okay, instead of that, now red color, here you can see the green color cassette size, means this width is 14 inches. Okay, the long width is the width of the cassette is in 17 inches. So in earlier in red area, you can see the red cassette example. 17 is the width and 14 is the height of the cassette. It is a proper. In case if you place the green way of the cassette, there will be a chances of CP, costophoric angle will be not included in the cassette. Then what will happen? If it is suspected pleural effusion, then you need to repeat the radiography. Here mistake who done? When you are the technologist or one person who is going to take the radiography, not place the cassette appropriately. Example, another aesthetic body habitus are there here. Now, instead of the cassette placing on red border, you can see that instead of that, you placed in a green border. You can see the green border way. You can see here again, the costophoric angle are not included in the cassette. This one you'll come to know after taking radiography only. By the time you already exposed the patient, already given instruction to the patient, and time also wasted. The more than that, unnecessary radiation exposure is given to the patient. So if you use a proper cassette size according to the body habitus, you will reduce unnecessary radiation exposure as well as the time of the exposure, time of the radiography. So what are the different factors affecting in the formation of the image? Contrast, density, sharpness. These are the part, these 3 already in between I included in previous slides. Magnification and distortion is very important, as I mentioned earlier. I'll include it in later as I explain. So you can see this is a magnification. It is very important. Okay, whenever you are placing the object in the sense patient, is better to place the patient closer to the cassette so that you can avoid the magnification of the any area. Okay, it means as the object to OID, you can see here OID, object to image distance, reduces lesser the magnification, lesser the magnification. Sometime, example, chest X-ray PA view, the distance between the heart and the cassette size, even though patient, if the patient is touched on the cassette, still the distance between the heart and the cassette size you can't reduce. So that time, source to object distance, source to object distance should be increased. That's the reason whenever you're taking radiography of the chest PA, the distance from the cassette to source or means X-ray tube will be kept 180 centimeter. For all other radiography, we keep 100 centimeter. Other than the chest X-ray PA view, other than the cervical spine lateral, we keep remaining every radiography, we keep 100 centimeter. Is very easy to remember. So C-spine also again, we wanted to avoid the magnification of that. That's the reason 100 centimeter will be used. So same way, this is what I given an explanation here. As a patient is closer to the cassette, the lesser the magnification, or sometime the distance between the patient and the film, you cannot reduce at all. So that time what you need to do, the distance between the film and the source should be increased. Okay, based on that only you can reduce the magnification of that. The same time, whenever you positioning of the patient, it is very, it is very important to be true lateral, true PA or true AP view. So that time you are going to get undistorted projection or undistorted image. You can see here the femur radiography. This is which is properly true radiography, where you can see here the another radiography. It is not object to uh, the film or the image receptor. It's not parallel. You can see these all different examples, not parallel. Because of that, there will be a elongation. So now I hope this, I hope the basics terminology, the basics radiography, basics of forming the image in the film, I hope you understood. Now I'll going to explain about the chest X-ray PA view. The radiography, you should know the is it true? I mean, whatever radiography you have taken, it is proper or not. You have to evaluate yourself. So those are evaluation criteria. If it is these points are included, means you are going to get a 10 out of 10. So these are all points I'm going to explain in this chest radiography today. First, we'll start with the chest X-ray PA view. So these are the indications. I no need to brief it because since you are MD radiology, so you senior residents and all there. So these are the indications. When it comes, they will be suggested for a chest X-ray PA view. So whenever for the adult patient, if it is chest X-ray PA view comes 35 into 43 or 35 into 35, means 14 into 17 or 14 into 14 inches cassette will be used for adult. If it is children or sometime we had to take the portable radiography in NICU, that time 12 into 10 inches cassette will be used. So this is the posterior anterior projection. Since rays are passing, entering through the posterior and exiting through the anterior projection. Okay. So as I said, whenever we are taking chest X-ray PA view, we are going to have the 6 feet distance from the cassette to image, from the cassette to X-ray tube or focal distance, or 180 centimeters. So here you can see now indications for what are the indication I shown. What are the contraindication? Usually contraindication is pregnancy. If the suspected any pregnancy is there, we are not going to do the chest X-ray unless it is very important, unless it is necessary with the proper protection going to take the radiography. So that's a contraindication. Next come to patient positioning. Patient positioning. Now we'll ask the patient to change the gown. Hospital gown will be provided, and as I shown earlier, whatever metal parts are there, metal anything radio opaque are there on particular area or in the neck or in the in the chest area, should be asked to remove. Okay, after that we'll ask the patient to come forward and ask the patient to keep the chin on the top of the cassette or top of the vertical bucky, and anterior part should be touched to the cassette. That's a patient positioning. Next comes to the part positioning. Now patient positioning is ready. Patient is PA positioning. Everything is ready now. Now part positioning. When it comes to part positioning means we are going to adjust the patient according to the what X-ray we wanted. Part positioning means as per the radiography suggested by the consultant, we are going to adjust the patient part. Now we are going to take the chest X-ray PA view, right? Now we'll ask the patient to fold both the arms should be folded, and you can see here the hand will be and kept top of the waist level, and anterior part of the shoulder we'll ask the patient to touch to the cassette. If it is not patient not able to touch, you can just slowly push forward, and I'll ask the patient to touch to the cassette. In case sometime patient not able to do this position, usually for aged patient above 45 50 age, they are not able to do this positioning because they are not able to fold their arms and keep on top of the waist. So that time you can ask the patient to hug the vertical bucky or cassette, or the both arms should be encircled to the bucky or cassette. Okay, these are two methods you can adopt during the part positioning. Then after that, what we going to do now? Cassette, patient positioning, part positioning, everything is done. Now distance is kept 180 centimeter. Now we are going to do the, see, this is what I explained here, how we are going to do all the positioning, how we are going to have the patient positioning and all. Now, first part, we had to ask the patient to take a deep breath and hold. One attempt before exposing to the radiation, we had to ask the patient to take the deep breath and hold. One attempt we had to do. Then we had to tell the patient the same method will be asked again to do. You had to hold the breath. That's one. Next, by the time we had to make the central, the X-ray tube has to be made a center of the particular area. Now we are going to take the chest X-ray PO view. So central ray of the X-ray tube should be at the level of 7th thoracic vertebra, or at the level of inferior angle of the scapula. Inferior angle of the scapula, central ray for chest X-ray PO. Then proper collimation is very important. Proper collimation, because we're going to take the chest X-ray. We wanted to see the only chest area. We don't want to see liver. We don't want to see kidney, or no need to see any other part, or neck, cervical spine. No, we had to collimate properly, because we are going to see, whenever you collimating, you can see here just 5 centimeter above the shoulder joint, upper collimation, and lower collimation. You can see lower border of the chest. When you touch the patient, you are able to, when you touch that palpably, you can make out lowest 12th rib. If it is included, that's more than enough. And as I mentioned, orientation of the cassette portrait or landscape. I give an example earlier. And what type of cassette you are using? 17 into 14 or 14 into 17 cassette will be used. So what is the radiation exposure are you going to give? 100 to 110 kVp, 4 to 8 ms. This is high kVp technique. High kVp technique, what you will do? You are going to increase the kVp and decrease the MAS. Maybe 2 to 3 MAS also is enough, more than enough. Okay, sometime for the adult patient. In case if you are not using the high kVp technique, you give somewhere 50 to 60 kVp and around 15 to 20 MIS. Okay, so SID 180 centimeter and grid. Most of the places nowadays, even vertical bucky has a grid. Earlier day, there was no grids in the vertical bucky. Only on the table bucky used to provide the grids. But nowadays, even vertical bucky also will be provided. So grid is yes. Then after taking radiography, now you're going to check the radiography. Is it proper? How you're going to see? First, you are going to see about entire lung field should be visible from the apex to the lateral costophoric angle. Okay, chin should not be superimposed in any structure. That's the reason we ask the patient to we ask the patient to keep the chin on top of the bucky. Okay, then arm are not superimposed or lateral chest wall, so that we can avoid overlapping on the pleural area or on the chest area. Okay, sternoclavicular joint are equidistant from the spinous process. This is very important. Most of the time when you're writing the radiography, you see reporting time, you used to see that there is a slight oblique of the chest PA. Why you are mentioning the slight oblique? Because the spinous process, sternoclavicular joint is not equidistant from the spinous process. That's the reason. So clavicle will be same horizontal plane, and maximum of the 10 posterior ribs, it should be visualized under the diaphragm. Around 5th to 7th anterior rib, if it is seen, it means the breathing technique what you given to the patient is proper. If it is less than that, means patient not taken proper breath. Before that only you exposed, or patient after exhaling the breath, then you are exposed. Okay, so clear vascular marking lung should be visible. If it is proper KVP MS is given, means the clear vascular marking are seen. So what are the common fault whenever you're taking radiography? As this one I explained already. If it is, we want to avoid the scapula overlapping on the lung field, right? For that reason only, what we do, we will ask the patient to uh, you know ask the patient to flex their arms and keep the hand on top of the waist, and right. Sometime, as I mentioned, old patient is not able to do that time, you can find you can ask the patient to encircle the arms around the vertical bucky. That can be done. Okay, so centering ray, it's very important. Patient rotation, if it is there, then there will be heart size you are not able to measure properly. That's very important. Same time, if it is proper breathing, if it is not done or rehearsal not done before exposure, then you will not able to see the 5th to 7th ribs. Okay, so always we should have the proper patient preparation, proper marker should be placed on the patient. And whenever female patient comes, see, these are the common artifact you can see here in this area, common artifact, because the hair overlapping on the upper area or apex area is very common. So always we should see that the patient properly folded, avoided the hair overlapping on the chest area. That must be assured. So I hope there is no, I hope that you understood very well about chest X-ray PA view. At the same time, we'll go ahead with the chest X-ray AP view. Usually, chest X-ray AP views are taken when a patient not able to sit or stand, or suspected any trauma, or suspected any other fall from height or some other reason, or maybe in ICU, unconscious patient, any suspected such things are there, means we are going to take the PA view. So here, PA view, whenever we're going to take, again, patient will be lying down on supine positioning. Both the arms are kept beside of the patient. Okay, now patient positioning is over. Next is the part positioning. When we're going to see the part positioning, what we're going to see? See, now this is the mid sagittal line of the patient. This is the cassette. Okay, this is the cassette. So mid sagittal line should be perpendicular to the cassette. Perpendicular to the cassette. That's a perpendicular, we say. Sometime if you are taking lateral view, coronal plane, this is the coronal plane, this is the sagittal plane. This coronal plane will be parallel to the cassette. So this is coronal plane will be parallel to the cassette. Sagittal line will be perpendicular to the cassette. So this is the two terminology you should be used whenever you are mentioning about part positioning. If you are not used this one, you are going to get the reduced mark in your paper. Okay. So if it is PA or AP view, sagittal line will be perpendicular to the cassette. If it is lateral view, the coronal plane will be perpendicular to the cassette, or sagittal line will be parallel to the cassette. Okay. So now you see here, patient is lying down in supine positioning. Now the distance between the cassette and the focus distance is 100 centimeter. Here again, breathing instruction, proper breathing instruction, everything will be given properly, as I earlier explained. Then after that, sentinel ray. See here, previously the PA view, lower border of the scapula, so that will be at the level of 7th thoracic vertebra, or if it is AP view, jugular notch, 7 centimeter below the jugular notch, the centering ray. Okay. So this is, now we are going to identify here, we are now going to expose the centering ray here. From the jugular notch, 7 centimeter distance should be there. Again, collimation, same method how you used in the PA should be used. Orientation of the cassette, same portrait or landscape. Detector size or cassette size 35 into 43 or 43 into 35. Exposure factor, again here, high KVP technique if you are using 100 to 110, MAS 4 to 8 MAS. If you are not using high KVP technique, 50 to 60 KVP, 15 to 20 MAS. SID, source image distance, 180 centimeter. Sorry, here it's supposed to be 100 centimeter. Okay. If it is grid, yes. If you are taking in this radiography AP view in department, the grid is S. If you are taking this AP view radiography portable in ICU or in post-operative ward or anywhere, the grid will be no, because you are not using grid there. That's the reason. So what are the difference between PA and AP view? I listed here. You can see here, posterior anterior view. Whenever you're taking, patient is in standing or sitting positioning, wherein AP view, patient will be in supine positioning, and PA view, no overlapping of scapula on lung field. You can see here the PA view, no overlap of the scapula. You can see where in PA view, the overlap of the scapula in bilateral both the side. Okay. Clavicle is not foreshortened in PA view. See here, not foreshortened. Where in AP view, there is a foreshortened of the clavicle view. A ribs course oblique in PA. See here, black line is an oblique, where in AP view almost horizontal in the head of the lateral, then it is caused the oblique. No cardiac magnification in PA view. Why it is not magnified? because of the distance of the objective to source is increased, made it to 180 centimeter. That's the reason. Okay. No fundic air bubble seen. You can see here the fundic air seen in PA since patient isn't standing in a erect positioning or sitting positioning, where in PA you're not able to see that. So these are the difference. So image technical evaluation, this is already explained in a where uh, the entire lung field should be seen, chin should be kept. These all points I already explained. If you follow this properly, you will get the beautiful chest X-ray or PA or AP true view. Next, I'll go ahead with the chest X-ray special view. I'm going to explain two views, only two views, which is the apical view and the lordotic view. So first we'll go ahead with the apex view. Here we are going to see the apex of the lung, where usually in the chest X-ray PA view, the upper ribs, first and second or third ribs will be overlapped. That is the reason this, to in case anything lesion are there behind the ribs, we are not able to make out small nodes or anything is there not able to make out. That's the reason we are going to take this view. When we taking this view, there are three different methods are used. But anyway, nowadays because of the chest, CT chest, I am not seen this radiography maybe since 5 years. But still we had to know about this. Now example you can see here, first view or projection A, projection B and projection C. Okay, now patient is in PA projection, right? Here there's a positioning already I explained in how we are going to do PA positioning of the chest X-ray. Same, there is no changes in this. Where central ray, you can see central ray angle 30-degree caudally towards the foot, and the ray should be past 7th cervical spinous process, because we can make out 7th spinous process of the cervical in case anything lesion are there behind the ribs, we are not able to make out small nodes or anything is there not able to make out. That's the reason we are going to take this view. When we taking this view, there are three different methods are used. But anyway, nowadays because of the chest, CT chest, I am not seen this radiography maybe since 5 years. But still we had to know about this. Now example you can see here, first view or projection A, projection B and projection C. Okay, now patient is in PA projection, right? Here there's a positioning already I explained in how we are going to do PA positioning of the chest X, same, there is no changes in this. Where central ray, you can see central ray angle 30-degree caudally towards the foot, and the ray should be past seventh cervical spinous process, because we can make out seventh spinous process of the cervical at present this tube angulated. So every nowadays digital numbers will shown. In earlier any old equipment is there means needle will be shown in angulation. Okay. Okay. The same time, now this is the projection A. Now projection B. Projection B. Now patient will be in AP projection. You can see here 30-degree cephal angulations are given. 30-degree cephal angulations are given. Okay. To the centering ray where it is passing at the level of sternal angle. Okay. Now there are there is a one more method. Okay. So this three projection are invented by three different authors. It is mentioned in the Clark positioning and as well as the Merrill's positioning book. Three different authors. That's why three different projections. At the end, the result we are going to see the apex of the lung only. Okay. So here, in case coronal plane of the patient 30-degree angulated from the cassette, then the centering ray will be no angulated horizontal ray. Okay. In case patient not able to rotate the 30-degree, if it is older patient, 15-degree coronal plane rotated and remaining 50-degree rotated by the X-ray tube. So that is what this is the alternative views are mentioned here. In case patient unable to recline 30-degree, you can see that, okay, we are going to adapt patient reclining 15-degree and as well as tube angled 15-degree to make the 30-degree angulations. Okay, these are the three views are taken to see the apex view. So after taking, you can see this is the image A patient. This is the patient B image. This is the patient C image. At the end, you are going to see everything is going to see the apex of the lung with the 30-degree cephal, 30-degree cowded or 30-degree patient and 30-degree tube central ray. When you make, you are going to see that. So another one more important view, that's a lordotic view. This technique is used to see the middle lobe of the lung. In case any collapse of the middle lobe, maybe due to the interlobular pleural effusion, we wanted to see that, because in the PI view we are not able to see upper and lower lobe. In between that it will overlap. We are not able to make out it is in middle lobe or lower lobe, upper lobe. That's the reason. Okay, so this views will be taken. Here you can see that the patient coronal plane 30 to 40-degree angulated from the cassette, vertical cassette. Okay, so where we are going to do the centering ray of the middle of the cassette. Centering ray will be mid of the cassette. So coronal plane of the patient will be dorsiflexion. You can see here dorsiflexion about 30 to 40-degree. Then centering ray will be passed through that at the level of mid of the cassette, because we are going to see the mid lobe of the patient. So that's a lordotic view. So whenever you're taking, I'm almost into the few more slides. Whenever you're taking, these are the image parameters should be kept in mind. Choice proper KVP or dual energy subtraction. In case if you are using the most of the places now DR are there, so you should use the proper parameters. Maintain the general contrast. To maintain that, you should use the grid. If you use the grid, you can have the beautiful, because the grid will remove all the secondary rays originated from the bones or scattered rays originated from the bones and will be removed by the grids. So only primary rays will be reached to the cassette. So you will have the good contrast, good resolution image. In case somewhere if it is not having the grid, you can have the air gap technique. But whenever you're using air gap technique, you should be accurate, and you should well versed with the technical or positioning part is very important. And always consider about magnification factors. For that, to avoid the magnification, you should know the F FFD, focus film distance, or SID, source image distance. Both are same. So that should be, you are well aware of that. And exposure time related to subject movement. Always, whenever you're taking chest x-ray, you will ask the patient to take a deep breath and hold. After that only you should expose. When taking a breath, if that time if you are exposing, there will be a chance of movement artifact. Patient will be taking breath during that time. So that's why always exposing the radiation to the patient, it should be on holding the breath. Then radiation protection, it must be followed. I think in earlier slide, I'll just go back. You can see in this image, to avoid the radiation exposure to the pelvic area, there is a curtain, lid curtain are used, so that unnecessary radiation exposure to the pelvic area can be avoided. This is a good adaptation. If you are asking the technologist to do this, it will be a good adaptation. And as well as collimation anyway, that's one of the important part of the radiographic positioning. So these are the points of the image formation. So these are the books you can go through that. Christensen for to learn about physics, basics of positioning and all. Clark's positioning in radiography, any edition, 10th, 11th or 12th edition, or Chesney radiography for the 6th edition, or any edition, is beautifully written. You can go through that and you can understand, easily you can understand and you can learn about it. So with this, thank you very much. And if you have any clarification, anything, you can contact me for this number anytime. Um, if you have any
Thank you. Thank you,
questions,
Mr. Shetty, for this excellent class. And I am sure, I mean, even I learned so much new from, how to approach a question like this, or how to think about it like this. So I think it was really, really good for all of us to learn. And I'm sure for the students, because this is the first time, Mr. Shetty, that we are having a lecture on radiographic positioning in the last, this is the fourth year of my work with the National Board for webinars. And we should have had you on this thing much earlier. Yes. So, any questions from the trainees? Because this is something very, very important. Because this is, if you don't know your chest X-ray, there are high chances of not passing the exam. If I'm the examiner and if I ask you chest X-ray, where will you position the central beam? Why is the FFD 6 feet and not less. If you don't answer those questions, if you don't know, supposing you say the centering will be done at say T4, T3, but how will you know it's T3, T4?
Yeah.
So if you have to, so those are the kind of questions, and I'm sure Mr. Shetty will agree with me that radiography will be learnt only in the radiography room. You will have to go there, you will have to do it yourself. So I expect all of you to please go tomorrow to your departments, and please, 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 before you take the exam, do one chest X-ray on your own. That is the least you can do, least. So I think there are some questions, Mr. Shetty.
Yeah, yeah.
For the constraints of time, we need to take them quickly.
I'll
Patient preparation slide for PA view.
I'll show you
Round.
one question regarding show the difference between AP view and PA view.
Yes, that is a favorite question of the examiners also.
Yes,
So
yes.
please click this slide, what sir
I
is
can take the
showing us.
screenshot of this.
Yes, please take this. Please take a picture of this.
Yeah, and as well as this is how I explained
Yeah.
in questioning. And as well as I just, since ma'am mentioned about 180 centimeter, see, as I mentioned here, the distance between the bucky and the heart, even though patient anterior part touched on the cassette, we are not able to reduce more the distance between the object to the cassette. That's the reason we increase the distance from the object to exposure. We made it to 180 centimeter. Okay, so that we can avoid that magnification of the heart. This is the physics behind keeping the 180 centimeter.
Yes. So in other radiographs, like in the X-ray hand and all, you don't need to avoid any magnification. So it's only in the heart because X-ray chest is a modality where you can get an idea of the heart size. You are supposed to read the heart size directly from the chest X-ray, and that is why you have to avoid magnification. And that is why it has to be kept at 6 feet or 180 centimeter, as sir has just explained it to us.
Yes.
So this is the reason, which is a very favorite question, and you in any way you must know about this. And so I think those are the questions. I can't see any other question.
Yeah, there is a, can you show the patient preparation slide for PA view
That,
just again?
that you have see.
Yeah, I think Dr. Jumana madam asked.
Okay.
Madam, preparation of the patient usually for the chest X-ray PA or chest X-ray AP positioning. We should ask the patient to remove all the metallic part and particular area wherever you're going to have the radiography. Especially for the female patient, we should ask the patient to change the dress into hospital gown. That's the most important thing.
Yes. Yes.
Um,
There is one more question, Mr. Shetty, that is repeat the RAO and ROP. I think they're meaning right anterior oblique and right, I don't know.
yeah.
Right,
Yes, yes.
what is
RAO,
meant
right
by this?
anterior
Yeah.
oblique. I will show. I think to avoid apparently cardiomegaly. Yeah, yeah. 100 centimeter is kept to avoid the magnification of the heart. Apparently we're going to see avoid the cardiomegaly.
So right anterior oblique position. Yeah.
Yeah,
That's
yeah.
what I want to see.
I'll come to that right anterior. Yes. This one. So RAO, right anterior oblique. You can see that patient will be in oblique positioning where right side of the patient will be touched on the cassette and where patient tilted towards the posterior, that's known as a RAO. From the prone positioning, we are tilting the patient towards the posterior, that's a RAO. And similarly LAO, left side of the patient will be touched on the cassette, and again from the posterior positioning of the patient, we are tilting the patient towards the posterior, known as a LAO. Wherein LPO, again here, right side of the patient will be touched on the cassette. Now in RPO or RAO or LAO, patient will be in supine, prone. Note again, in LPO or LAO or RAO, patient will be in a prone positioning, and we are tilting the patient towards the posterior. Okay, where in LPO, patient will be in supine positioning, and we are tilting the patient towards the anterior. Okay, so to remember the L, left side, or R, right side will be touched on the cassette. Remember the P means posterior. Posterior part of the patient will be touched on the cassette. See here, posterior part of the patient is touched on the cassette. Where LAO, L is the left side is touched on the cassette. A, anterior part of the patient touched on the cassette, and we are tilting the patient opposite to anterior. Where here, opposite to posterior. It's very simple.
Thank you, Mr. Shetty. That really cleared my doubts also. How to, and I think that's a good acronym, LPO. L is the side which is touching the cassette. P is also touching the cassette. So
Yeah.
that is how you remember it. It's a wonderful way to explain. So thank you very much for your time and excellent class that we have all enjoyed. I hope to see you again. I think we have a class scheduled for you in the next time also.
Yes.
So thank you very much. Thank you all trainees also for joining us.
Thank you so much, ma'am, for the opportunity. See you. Bye.
Bye-bye.
Thank you, trainees and faculty member, for joining this session. Thank you.